Hi, everybody, and welcome to the Canadian Spinal Cord Injury Standing and Walking Assessment Toolkit training session. I'm Kristen Walden. I'm a physical therapist here in Vancouver, BC, and I work with the Praxis Spinal Cord Institute as a national clinical liaison. I'm also a therapist here at our acute and rehab hospitals. And joining me today is Shane McCollum, also a physical therapist from the Stan Cassidy Center for Rehab, and he'll introduce himself a bit further on. So what we wanted to go through today was to give you a bit of background on the Canadian Spinal Cord Injury Standing and Walking Assessment Tool. We'll go through a more detailed review of the tool, including staging with some case studies, each of the outcome measures collected, and looking at what resources are available to you. And then we'll talk a little bit about how the standing and walking assessment tool can be used. So in terms of background and looking at why the SWAT was developed, in 2012, Dr. Kathy Craven and a group put out an environmental scan, which really looked at the current practice in inpatient rehab across Canada. And it looked at identifying in different domain areas where practice was at. And what that group found was that in the area of walking, despite a lot of literature on walking, there weren't really any guidelines in terms of best practices in walking assessment, that was kind of a gap for us here in Canada. And so the Praxis Spinal Cord Institute brought together a group called the Canadian Spinal Cord Injury Standing and Walking Assessment Tool Group. And really what that is was an integrated community of research and practice. So it involved frontline physiotherapists from 9 rehab centers, as well as a group of expert researchers from across the country. And the goals of this group were to standardize a clinically useful way to track standing and walking progress for clients during inpatient rehab. Also to develop a strategy to start to collect that information and use it, and to build a clinically relevant database where we could access that information being collected by therapists. And so if we look at the SWAT, or the Standing Walking Assessment Tool, it has 2 components. The group developed a staging tool, and this staging tool really allows us to define a standardized functional ability in terms of standing and walking, at which we can collect the different outcome measures. And so you can see on the right-hand side of the screen there, the outcome measures that are collected at the different standing and walking functional stages. Each site that participates in collecting the standing and walking assessment tool chooses a level to collect it at. So all of the sites are collecting what you can see here as the SWAT in green, which involves collecting the staging. So staging their clients in terms of standing and walking functional ability, collecting the Berg Balance Scale, a modified timed up and go, an outcome measure called the Activity Balance Confidence Scale, as well as a modified 6-minute walk test and a 10-meter walk test. And we'll go through these, Shane will go through these in more detail later. Some sites are collecting the advanced SWAT, which also means they're collecting a modified version of an outcome measure called the SCI-SWAT. And there also is a research SWAT level that sites are able to collect, which includes collecting a modified mini-best test. So basically, once your site has decided what level of outcome measures they want to collect, they'll collect those on all of your clients. So if we have a look at those different outcome measures, you can kind of ask the question of, when do you decide to perform these outcome measures? So we really tried to standardize when these were collected. And the way that the group decided to use to determine when those outcome measures were collected is for each measure, we defined a threshold. And that threshold stage, or the functional standing and walking ability a client needed to have to be able to do that outcome measure, was really based on the purpose of the outcome measure, the floor effects that had been found for that measure, and really what the minimum functional ability someone needed to have to be able to administer one of the measures. So the process for collecting the standing and walking assessment tool. So when a client is admitted at rehab, you will determine the stage. So you use the staging tool and determine what SWAT stage the client is at. And then you'll perform all of the outcome measures that that client meets the threshold for. As the client is going through inpatient rehab, ideally, you'll be staging them at regular times, and many centers have implemented adding this to their weekly rounds. As a client meets a new threshold to complete another outcome measure, ideally, you would complete that outcome measure as well. And then at discharge, again, you're going to determine the SWAT stage that your client is at and repeat all of the outcome measures they've met the threshold stage for. So again, that threshold stage is really just a standardized stage in their recovery for administering a specific outcome measure. So you can see here, if, for example, your client came in at admission and you decided that they were a SWAT stage 1C, you would complete the Berg balance scale. If they then progressed to a 2C, at discharge, you would at discharge complete the Berg balance scale again, as well as completing the modified TUG and the activity balance confidence scale. If your site is collecting the basic SWAT. If your site was collecting the advanced SWAT, you would also complete the modified SciFAP at discharge. So how did we determine these SWAT stages? And it was really based on this article that came out in 1998, so quite a while ago, where they grouped ambulatory capacity into 4 categories. So the first being non-ambulatory, the second being therapeutical ambulatory capacity only, so the need for a therapist to ambulate. The third being where the client had some functional ambulatory capacity, and the fourth being full ambulatory, so not a lot of walking disturbance. So our SWAT stages were based on that. And then we did add some sub-stages to be able to make it more granular and meet the needs of when to do the different outcome measures. The SWAT itself has had a variety of validation and testing. So we've looked at the qualitative validity and clinical use back in 2019. We've looked at the validity and responsiveness of the tool itself, and that was in spinal cord in 2022. And then we've looked most recently at the inter-rater reliability of the staging tool. Obviously, we would like to make sure that all of the centers are staging consistently. And that publication was recently submitted. So I'm going to hand it off to Shane, and he's going to go through a lot more in terms of how you stage, what that means, and some sample cases.
Thank you, Chris. As Chris mentioned earlier, my name is Shane McCullum, and I'm a physiotherapist and the research manager at the Stan Cassidy Center in New Brunswick. And I've been involved with RISCR since 2011 at our site, and then as the SWAT lead at our site since its inception here. So going through the SWAT staging, I'll break this down more in future slides, but as Chris mentioned, there's it goes from a 0 up to a 4, and depending on what stage, there's different thresholds to meet certain stages, and then that's how you would determine which outcomes to complete. So we'll go to the next slide. So the way that is broken down here for a 0 is 0.0 or 0.5 is somebody who would not be able to stand at this point in time. So they would be someone who's able to sit. And the differentiation between these two levels is whether they're able to sit for 60 seconds, without using arms to stabilize on a firm surface with no back support. So we often use a plinth in the physio gym here, and where we would test this out. So if they're unable to sit for 60 seconds with this setup, then it would be a 0.0. And if they are able to do that, then they would be a 0.5. And then moving on to the ones. So there's 1A, 1B, 1C. If we can go to the next slide, perfect. So these are individuals who would be able to stand with assistance, but are unable to just take steps at this point. And I just want to point out, as you go through, you'll see that we mentioned anti-gravity muscles. And those are looking at the tibialis anterior, soleus, quadriceps, and glutei on each leg. So there's actually 8 muscles that we're assessing for this. So for a 1A is somebody who would be unable to stand without total assistance of a gait aid or orthosis or therapist. Typically no voluntary lower extremity functional movement, so muscle grades 1 or less in the anti-gravity muscles. And in order to be staged a 1A versus a 0.5, the patient must have attempted a stand. So they've never actually attempted a stand, but they meet the other criteria. So they have, flickers of movement. They would still be considered a 0.5. Moving up to a 1B, the difference is that it's partial assistance instead of total assistance. And then also with the voluntary movement, they have a bit more movement in the legs, and somebody would have, but they would still have grade 3 or higher in less than 4 of the 8 anti-gravity muscles. And for a 1C, someone who's able to stand independently with minimal assistance, usually for short amounts of time, so less than 30 seconds, and would have a grade 3 or higher in 4 or more of the 8 anti-gravity muscles. And then moving on to the 2s. So this is individuals who are able to walk but still require hands-on assist. So there's max assist, mod, and min. A few things to point out. So for a 2A, they must be able to initiate reciprocal steps through voluntary lower extremity movement, but requires maximal physical assistance of at least one person. So it could be multiple individuals helping. And it could include assistive devices. And for 2A, parallel bars and suspension harness can be used as well. You'll see for 2B and 2C that parallel bars or suspension harness are no longer allowed as gait aids. And as you'll see from here on out, bilateral KAFOs are not allowed for any of these levels. So moving on to a 2B is somebody who requires moderate assistance, so 25 to 50%, but only of one person. So only one therapist is allowed as opposed to multiple. Still allowed to have walking aids or orthoses, like I mentioned before, with the exception of KAFOs, and no parallel bars or suspension harness. And for min assist, they would require less than 25% of total effort from one person. And once again, at the same as above, no KAFOs, parallel bars, or suspension harness. Then moving on to the 3s is these are people who do not require hands-on assistance in order to walk. For 3A and 3B, the distance is approximately the same. So looking at people who can walk between 10 to 100 meters, but for 3A, they still require supervision. So at our center, this would be somebody who, if they were walking from their room to the cafeteria, would still have somebody walking with them, not hands-on, but we wouldn't necessarily trust them balance-wise to do that on their own. Whereas for a 3B, these are individuals who would walk, from the room to therapies, room to cafeteria independently. We would feel safe doing that. But they're still not at the point where they would walk long distances in the community. And in order to get that is usually if they're able to walk, greater than 100 meters independently, then they would be up to a 3C. And this is still assistive devices and or orthoses are still allowed at this point. And then for a 4, so this is somebody who has the ability to ambulate full-time daily at home and in the community with no assistive devices, orthoses, or physical assistance. So at this point, there's minimal impairment and someone can walk as their main mode of transportation throughout the day. So we'll go through, just to mention that, we'll go to the next slide. So someone may achieve a threshold stage as per the definitions, but may not be able to complete the measure associated with that stage. So about 80% of the time, the measures associated with the stage will be able to be completed for 80% of cases, but there's always exceptions. So in these cases, you should still mark that they achieved that stage, but include the reason why they were unable to complete the outcome. So for example, a client requires physical assistance of one person and the use of parallel bars to prevent a fall during most attempts at walking. So for this, they would be staged at a 2A, because their functional level matches that definition. But in the modified tug conventions do not allow for the use of parallel bars. So the scoring form is completed with an assistance rating of 6 and the maximum time recorded. And I'll explain that later on when we go through the outcomes. And then once the client is able to attempt walking outside of the parallel bars, it would be a good time to complete the modified tug in order to get a score. And it may not match up with when they met the threshold, but that's okay. And that same scenario can happen at any threshold where they meet the definition for the given stage, but can't complete the measure in a way that is compliant with the standards for that measure. So we'll go through a couple of case studies here. And just to let you know that I'm not gonna pause for very long after each page before I give the answer. So if you're watching the recording, you may want to pause it once I go through the slide to give you a chance to determine what stage you would give them before you get the answer. So the first one is Dana, who had a C6 AISD injury sustained in a motorcycle accident. Was admitted to your rehab facility 2 days ago. In our initial assessment, you note that they are able to sit independently on a firm surface, hands-free for 1 minute. There's voluntary lower extremity movement in greater than grade 3 in all right anti-gravity muscles and left quads and gluteus, and able to stand independently in the parallel bars for 10 seconds. So at this point, if you wanted to come up with what Dana's admission stage and what outcome measures would be completed, I'll give it a few seconds and we'll move on to the next slide. Okay, so we'll move on to the next slide. And Praxis has done a really good job of coming up with a lot of different resources that can be used. And one of them is kind of a flow chart that you'll see on the right part of the slide to kind of determine what stage they're at. So looking here, can the patient sit on a firm surface at 90 degrees without upper extremities for 60 seconds? Yes. Can they stand without aids, devices, or help? Yes. So that can go down again. Does the patient have voluntary functional lower extremity movement and anti-gravity muscles? Yes, that was in 6 of the 8 muscle groups. So you move down again. And can they stand for greater than 30 seconds with minimal assistance? So they were only able to stand for 10 seconds at this point. So it would be a no. And then can the patient take steps with physical assistance? That's no. So they would be a 1C at admission. So determining outcomes, you would do anything that's above a 1C on the chart here. So you would complete the Berg balance scale at this point in time with the individual. And I just want to point out that even if somebody doesn't meet the full criteria for a lower threshold, they can still be bumped up. So even if they couldn't stand for a full 30 seconds, but they were able to take a few steps, then they could actually be up into the 2s because they are taking some steps, even though they don't necessarily meet the full criteria for the stage below. So we'll move on. And now we're looking at Dana again, 4 weeks into rehab, and she's walking with a 2-wheeled walker indoors for short distances, so about 10 or 20 meters with 1 person minimal assistance. So we'll give you a few seconds again to look that up. And then we'll move on to the next slide again, and we can look at the flow chart again. So this is, we can move down to about the middle. Can the patient walk without assistance, without physical help? At this point, it's no, because they still require some physical assistance. So we'll move over to the right, and can the patient walk with less than 50%? And the wording was minimal, which would be in the 25% range. So we'll move down. Can they walk with less than 25%? Yes. So that would be a 2C as opposed to a 2B. So they still require hands-on assistance, but it's only minimal assistance at this point. So you would complete the outcomes above. So you've already completed the Berg balance scale, so you don't have to do that one at this point in time. But you would complete the modified timed up and go at this point because you met the threshold. And you would not necessarily complete the ABC because that's only required at discharge. And the patient is not ready for discharge at this point in time. So we'll move on, and now we are at the point of discharge, 2 months into rehab, being discharged in 4 days. And for indoor ambulation, Dana is able to independently walk with a four-wheeled walker greater than 200 meters, and about 100 meters with a cane and standby supervision. And for outdoor ambulation is independent with a four-wheeled walker for 100 meters. So I want to point out that depending on which gait aid you're looking at here, the stage would actually vary. But chances are, looking at this where she's using the walker outdoor and for longer distances indoors, that would be her main gait aid used at this time. So we'll focus on the stage that she's able to reach with the four-wheeled walker. So we'll give a few seconds again for that. So moving down, about 2/3 of the way down, can the patient walk without assistance for more than 100 meters? And that's yes. So we go down to the bottom, and can the patient walk full-time without physical assistant aids or orthoses? And that's no, because she still requires a four-wheeled walker. So the stage at this point in time would be a 3C, and you would complete all of the outcome measures that are required at this point in time. So the Berg balance scale, the modified tug, the ABC, the 6-minute walk, and the 10-meter walk, because they're all above that level. And we'll move on with one more case study. So Jack is a 76-year-old semi-retired farmer who fell from a tractor and sustained a C4 AISC central cord syndrome. At admission to rehab, requires supervision to sit on the edge of the bed, can sit for a maximum of 30 seconds before falling to the side, and can stand in the parallel bars with moderate assistance of one physio to provide support at the trunk. So this one's a little bit tricky in that, and we don't have the flow chart after, but that's okay. So technically, Jack would not meet the criteria to be a 0.5 because he's not able to sit for 60 seconds independently. However, the fact that he's able to stand with moderate assistance trumps that. So you actually would stage him up at a 1B at this point in time because he's able to stand with moderate assistance of one physio. So it'd be a 1B, and you would complete the Berg balance scale at this point in time. So we'll move on to 2 weeks later, and Jack is able to stand and take 10 reciprocal steps with moderate assistance from 2 PTs. So one assisting at the trunk and one assisting at the legs. I'll give you guys a few seconds. Okay, so the big thing at this point in time is that even though it's moderate assistance, and when you look at the 2A, 2B, 2C, it's max, moderate, and minimal as you go down, the fact that he requires assistance from 2 physios means that he cannot progress past a 2A at this point in time. In order to be a 2B or 2C, it can only be assistance from one other person. So he would be a 2A. And at that level, you would do the modified tug with him. So we're moving on, I think, to after 4 weeks, Jack can ambulate 20 meters with a platform walker and hands-on supervision of one PT. So we'll give a few seconds. So at this point, he would be a 2C. And the main determinant between a 2C versus a 3A is that it's still hands-on supervision. So in order to be up in the 3s, there can't be any hands-on. So it has to be just supervision, standby at 3A versus the fact that he's hands-on means he's a 2C. There's no additional outcomes to complete at this time because you've already done the Berg balance and tug prior to that. So a week later, Jack has developed intense neurological pain in his feet and is unable to stand or ambulate due to pain. So he's able to sit on the edge of the bed independently with his feet dangling for more than 2 minutes. So we can restage here. I'll give a second. So even though Jack was a 2C a week prior to this, the fact that he's no longer able to stand and ambulate, you would actually bring him back down to a 0.5 at this point in time. So even though somebody has attained a certain level, it doesn't necessarily mean that they're going to keep gaining or stay at that level. Individuals can drop down levels depending on if their function decreases. So at this point, you would stage at a 0.5. And then we'll move on. And thankfully, Jack's pain has subsided, and he's able to ambulate 50 meters after 7 weeks with no gait aid and standby supervision. So even though he has no gait aid at this point in time, the fact that he still requires standby supervision would mean that he is still only at a 3A. So if you remember, the difference between a 3A and 3B is the fact that there's standby supervision for 3A, whereas 3B is independent. So he'd be at that level right now. And then we move on to discharge for Jack. And at this point, he's ambulating without a gait aid for 200 meters, requiring standby supervision required for safety as walking balance is impaired. So if you look down at 3C, he actually meets the threshold for distance required for 3C, but the fact that he still requires standby supervision would mean that his stage is actually still a 3A because he is not walking independently at this point in time. So at discharge, you would complete the Berg balance scale, the modified tug, and the ABC. For outcomes, you would not do the 6-meter walk or the 10-meter walk because those require a 3B in order to complete those. So hopefully those case examples helped with that. Now I'm going to go through some of the outcome measures that we mentioned before. So these are the main 5 from the traditional toolkit that we mentioned, and we'll go through each of them. So the Berg balance scale is just the traditional Berg balance scale that everyone's used to doing with the 14 items. It's completed once someone reaches 1B. And I will say that when we started doing this, I had a lot of pushback from therapists saying that the 1B was way too early to be completing the Berg. And although it is early, and a lot of times they're only able to do 2 or 3 of the items at that point in time, it does mean that more individuals attain that threshold. So we are getting more data than we would otherwise. And our therapists are certainly okay with doing that now, and they're used to doing that. But there was a little bit of pushback at first, and a lot of discussion as well with the SWAT, the Canadian SWAT group around was this the right point to do it? But it has worked out well. So that's the Berg. There's an example of one of how it scored. The modified timed up and go. So the difference between the regular versus the modified here is that you actually multiply the time by the assistance rating. So the assistance rating you'll see on the slide here from 1 to 6. So if somebody's walking independently with no gait aids or assistance, then they would have a 1. Versus unable to complete would be a 6. And then you can also have hands-on physical assistance of 1 person to assist with this as well. Traditionally, when our therapists do the tug, we don't have any hands-on assistance, so there's a bit of a modification as well. So it's a bit more informative because it does record the aids and assistance. It doesn't just have the time. And it allows testing in those who need physical assistance. But as we mentioned earlier, this has to be done outside of the parallel bars, so that will limit some people at that point. And it's consistent with what's done in the CSCI-SWAT as well. So the CSCI-SWAT has 4 items, and the modified tug is one of the 4 items. So if you're doing the CSCI-SWAT, there's no need to repeat the modified tug separately. You can do it within that outcome measure. I think the next slide has more. So just you start with in the seated position with your arm against the back or back against the backrest, arms on the armrest, toes on and behind the line. Start timing when you say go. Advise somebody to have comfortable walking speed and that both feet must fully cross the 3-meter line, and you stop the time when the back touches the backrest. So fairly standard with that. If the client is unable to attempt the modified tug or does not complete the test, then they're assigned a maximum time, which is 455 seconds, and an assistance rating of 6. Unable to complete. If someone's unable to complete it in that 455 seconds, then that you would also use that as the maximum time. And then you can see the scoring here as well. It does allow, you have the time and the assistance rating, you multiply the 2, and then you can divide by 9.1 seconds, which is the mean time of able-bodied individuals to come up with a task score. So it shows you, gives you a score based on the mean time that would be expected. I think that's all for the modified tug. The 10-meter walk is performed, so it's performed twice. So it's performed at preferred walking speed and fastest walking speed. You can use aids and orthoses, and there's a checklist on the bottom of the form to check off what outcomes were used. No bilateral KFOs or physical assistance, but typically in order to do this outcome, somebody would be at a 3B, which at that point they're able to walk without physical assistance anyways. You use a 14-meter track and you time the middle 10 meters, so that way they're already up kind of in their stride when they get to the start and the finish line. You start and stop timing when the toe of the leading leg crosses a line, and as I mentioned, you can document the aids used on below on the sheet. The 6-minute walk test. So the course has course is used with distances marked every 5 meters or less. Ideally, a round track is preferred or a long hallway. I know our center does not have a round track, so we use a hallway with 2 cones that are 30 meters apart. And you want to have as big a distance as you can in order to minimize the number of turns, which obviously people slow down on turns, so you're not necessarily getting your full capabilities if you have too many turns. Aids and orthoses can be used. Once again, no KFOs or physical assistance. And depending on someone's health, you may want to monitor vital signs when doing this as well. So the modifications for the 6-minute walk compared to at least how we traditionally do it at our center is the first little bit here is fairly standard. So initiating the start of the test when the patient starts to walk. At each minute, inform them of how much time is left and give standardized encouragement. Walking behind the participant, so you don't want to walk beside or in front because that can impact their pace. One difference is that the participant is allowed to stand and rest, but not sit. You can document the aid used, and you also record the distance at 2, 4, and 6 minutes and the total distance. So there's a spot on the sheet to do that. So that kind of gives an indication of how, whether they're able to maintain their pace the whole time or whether they actually slow down or speed up as they progress as well. And it's the total distance that's completed. So at 2 minutes, if it's 100 meters, and then between the 2 and 4 minutes, it's another 100 meters, then you would put 200 meters at that point. And then at 6 minutes, you put how much the total. And then the total distance is if they aren't able to walk for a full 6 minutes. So if they only walk for 5 minutes and they say, I can't do any more, then you would enter the total distance, the total time for the test, and then the 6-minute distance would be left blank because they didn't actually get to that point. We also use the Borg scale in order to look at perceived exertion. And we always have this printed out right beside so that we can show them the actual scale with the wording. We word it exactly as it is on this slide as well, so that is consistent, just to get another indication of how much exertion they feel like they were giving. And I think, yes, the ABC scale. So the activity-specific balance confidence scale is only completed at discharge. It's a questionnaire administered by interview, which includes 16 items. And it asks the participant what their level of confidence is. Someone can have 0, 10, 20, 30. So examples are asking somebody if they're walking around the house, if they're walking up and down stairs, what their confidence would be, walking outside on icy sidewalks. Some of this can be a bit tricky because if somebody had their spinal cord injury in the summer and they haven't had to deal with ice yet, or if they've kind of been secluded away in a rehab facility and they haven't actually done a whole lot of walking outside, they may not know what their confidence is, but it's still a good perspective to find out how they think they could do on that. And there was also a recent publication in physiotherapy in October 2022 that the ABC is one of the best measures for predicting walking ability at 1 year. So it's a very valuable outcome in that sense. And I must say too, it kind of gives our therapists a bit of perspective in terms of how confident somebody is. So sometimes you have people that are a bit too confident, and you may want to talk to them about, maybe even though you think you're 100% confident about walking on ice, maybe just take it easy, or use a different gait aid if necessary. And if someone's really not confident, then you may have to build that into any kind of outpatient therapy as well, in trying to build that confidence. So looking at the advanced SWAT outcome measures, so this is where the modified SCI-FAP, so the spinal cord injury functional ambulation profile, takes the place of the modified TUG, because the TUG is part of the SCI-FAP. So the SCI-FAP, is there's 4 tasks that are completed: walking on carpet, stand up and go, with obstacles, and using a step. So you want to explain and demonstrate the task, and then inform the participant that each task is timed. Give a rest period between tasks that's long enough for the tester to explain and demonstrate. You can use physical assistance and an assistive device and or braces as needed, and provide feedback and encouragement only after the task is completed. So you don't want to be doing it during the task. And you record the performance time. So if a client cannot attempt a task or does not complete a task, they're assigned the maximum time for that task and an assistance rating of 6. So the same assistance rating that we saw earlier for the modified TUG. And if a client takes longer than the maximum time, then they're assigned the maximum time. And upon completion of all tasks, you can calculate a total abbreviated SCI-FAP score. So it's nice that you actually get a full score at the end as well. Just to point out a few resources that we find helpful at our center. So there's a SWAT toolkit, which was developed by Praxis, and I believe Chris said that they're revising it right now with a new toolkit. So this includes all of the stages and the descriptions that I mentioned earlier, and how for each stage and what is required. It will also have the algorithm that you see kind of in the background here, with the checklist to go through to see what stage they're at. I also want to point out that our therapists, they really, I don't want to say struggle, but they have a hard time sometimes determining someone's stage. Not everybody fits really neatly into a stage. So every therapist has their own toolkit kind of on their desk. And when they're staging somebody, if they're having a hard time, then they're recommended that they kind of talk it out between their other therapists that they work with. If they still are struggling with that, I'd say I get a call, usually probably monthly, for one of our therapists, just asking me to help clarify what stage somebody would be. And then there's some that just are really tricky. And usually if I can't figure it out, or if we can't come up with it together, then that's usually when I reach out to Chris or somebody at Praxis, because chances are they've seen something similar that's come through, and we can usually, between all of us, come up with the right answer, the answer we're going to go with at least. So that's one thing, is taking the support from your local clinical site lead. I've also set it up that a lot of our therapists had a hard time remembering to stage all of their patients regularly. So at our site, I've set it up so that Fridays at noon, all of the therapists get an email reminder or a calendar reminder to stage all of their patients. And we found that quite helpful. Friday afternoons are usually when therapists do their weekly charting. So they kind of get that reminder before they go chart to fill out the stages. And that way it's just done more consistently. We don't have the situation where somebody met a criteria for a certain outcome measure, but it wasn't documented for 3 or 4 weeks, and then you're kind of off the track of how it should go. And then there's also some support from the Canadian SCI-SWAT group as well. Lots of resources that are available. And a few other resources, some videos that you can find on how to conduct the outcome measures. So there's a few of them there that you can look up. And I think that is all for me. I'll pass it back to Chris.
Thanks, Shane. And just a note too, to say that, one of the really cool things about this SWAT being developed with frontline physios as well as researchers was one of the things that we wanted to make sure where we ended up was feasible to collect in a clinical practice setting. So we didn't want to come up with this great ideological research, very complex measure that could be used. We wanted to make sure that whatever we came up with would be informative to clinical practice, but also feasible to collect, within the boundaries of what practice looks like. And so just to emphasize that the key pieces at a minimum are to be staging and collecting the outcome measures at admission and discharge. Like Shane has mentioned, and we've said, ideally you're staging on a regular basis throughout and able to collect those new outcome measures as the person becomes meeting the threshold for them. But at a minimum, admission and discharge is good. And the other thing to point out is this doesn't mean you can't use any of these outcome measures at other times with your clients. They're sort of meant to be the minimum in terms of when they should be used. If you have a client who you want to use things more regularly or use other outcome measures, feel free to use those in addition. Again, this is really meant to be kind of a minimum standard that we can all be doing the same way across the country. So shifting gears a little bit in terms of how can it be used. So if you're going to spend this time collecting these outcome measures and staging your clients as they come through rehab, how can you use that information? So again, this is just a bit of an outline of how that Canadian SWAT group that we've talked about sort of works. So they came together to create the measure, but the group still is in contact and connects. It has a leadership group, and that group really kind of led the development of these tools, leads ongoing development of different support tools, leads developing some clinical and research related questions that we want to answer with the information being collected, helps support the whole community of practice, supports the clinical leads at each site to implement some of these outcome measures, and helps develop clinical reports that we'll talk about in a little bit that can be fed back to all of you. And then each site has a clinical site lead. So Shane is the site lead for his site at St. Cassidy. And those clinical site leads are really those champions on the ground. They're an integral part of the Canadian SWAT group. And they also help you at your local site implement and use the outcome measures as well as the information that comes out of them. So they participate in that national community of practice as well in terms of feeding back What questions are important to your group clinically to start to answer with this standing and walking information that you're collecting. What information do you want to see reported back on a regular basis that will help you in your practice? So they really represent your local clinical physio group in this national group. So if we go back to the goals as a national group that we had in developing this, one was standardizing the way to track all of this progress, which is what we talked about so far. The others were really to develop a strategy. How are we going to collect this information? How are we going to be able to use it at a national level? How is there a clinical database? Can we put all this information together in a place where we can use it to answer some of our clinical questions? And so what the group decided was to use the Rick Hansen Spinal Cord Injury Registry. So this is a registry of patients who have new traumatic and recently non-traumatic spinal cord injuries. And it's a registry that's run across 30 hospitals in Canada, has over 11,000 participants in it to date. And the goal of the registry really was to start to create a Canada-wide observational look at what traumatic spinal cord injury looks like. And like I said, that's now progressed into adding non-traumatic. It's given us a platform to link researchers, clinicians, individuals with spinal cord injury, both to help in terms of clinical research, but also to help facilitate implementation of best practices. And the data that's collected in the registry, so like I said, the SWAT group, the Canadian SWAT group decided that would be the best place for all of us at our centers collecting this information to house it, to put it so we could access it all together. But just really quickly to run through, there's also other information in there about the same participants. So demographic information, information about their injury and how it happened, where they went for their acute care, how long they stayed, surgical procedures they had, different functional measures collected at acute, their neurologic diagnosis through acute. And then in rehab, again, it'll look at how long people are staying at your center as an inpatient, if they're having neurologic changes, so any improvements, complications they may be getting. Other functional measures are collected, including the spinal cord independence measure, quality of life measures. And then we're able to follow a subset into the community and look at 2 years after their injury, 5 years after their injury, how are they doing? Are they having to come back into hospital? What complications are they having? How are they doing in terms of quality of life and function? So the reason we wanted to include this was just to show you that the standing and walking information that you guys are working hard to collect and with all of your clients gets put into a place where there's access to this larger pot of information to answer the questions that we have as therapists. So who's using the SWAT? So right now there are 12 rehab centers in Canada, that you can see on the map here, that are using it. One in Kingston is using it, but isn't a part of the Rick Hansen Spinal Cord Injury Registry. So their information isn't going into that larger national pot at the moment. Site started collecting it in 2014, and we have standing and walking information on over 2,200 participants. So one of the things that's often a challenge in terms of being able to answer questions about individuals with spinal cord injury is there aren't a large number of people having at least traumatic injuries across the country. And so if we can bring the information about their experiences together, that enables us to more easily be able to answer some of our questions. And you can see the individual hospitals listed on the right here. So why use it? I think at a basic level, it gives us a common language to start to categorize standing and walking abilities for patients. So I know at some centers, the SWAT stages, which like we've talked about, were originally developed as a way to have a standardized time, functional ability to collect the different outcome measures. those stages have actually become a bit of a language on their own, in terms of describing someone's functional abilities. So in some centers, it's really to help facilitate communication even between their inpatient and outpatient therapists using that staging language. It gives us a standardized approach that's evidence-based to standard walking assessment. I think, like the rehab scan identified prior to this SWAT in a lot of centers, which outcome measures were collected on which clients at what time varied not only from center to center, but also between therapists in a single center. So this really gives us a standardized way to assess standing and walking. It also gives us a way to track and to communicate those standing and walking related changes uh, to teams, to our programs, but also to our clients. Um, and it's a nice way to ensure that you are assessing and reassessing using the same tools. And it really lets us start to follow those changes. It gives us, some centers are using the standing and walking assessment tool to develop guidelines in terms of, they've got a new piece of equipment. So, for example, an exoskeleton, and they're using the SWAT stages to define which clients they're going to are appropriate to access that type of equipment. So they're using it in terms of writing out protocols around access to new equipment at their centers. It can be used to guide the focus of our therapeutic interventions and priorities. There are some centers who have used those SWAT stages to say, once a client meets a certain stage, then we need to shift their therapies to focus on, this type of therapy. Um, we need to make sure we're doing standing therapies. Um, at an individual level, having those outcome measures and the results of them can help you also focus your specific therapies and priorities with each client in terms of really knowing what areas of, say, standing balance they're struggling with. And recently, actually, we've learned that therapists in Brazil are actually have found the standing and walking assessment tool, and are using that to focus their therapeutic interventions. It can also help predict standing and walking outcomes after rehab. I think that this has sometimes been a black box for us as inpatient rehab therapists in terms of knowing where people end up once they've left inpatients, if they don't come back and we hear about them as an outpatient. And so some of the research being done to answer the questions we've had clinically is helpful for us to be able to start to predict how these clients are going to do once they leave rehab based on their SWAT staging and outcome measures at discharge. You'll see in the toolkit, there are a lot of resources like Shane was talking about. One of the things that's in there is a summary of the most recent literature, so publications about that outcome measure. So it helps you determine, those reference values are in there to help you determine if your client is making true changes on the outcome measures. If it allows you to see what normative values there might be for individuals with spinal cord injury similar to your client, to be able to compare how they're doing to others. And it will help determine if your client's achieving clinically significant improvement in different measures. And again, the summary of this is all provided for you in the toolkit, so you can kind of reference what those values are. And this is just an example. So for the timed up and go, it'll give you the normative values for individuals with spinal cord injury. So again, this was done on individuals with AISD injuries in inpatient rehab, and it'll show you the kind of the mean overall TUG score, which is the norm value. And then it'll split it up for individuals with paraplegia versus tetraplegia. So you can kind of get a sense of how your client is doing compared to the norm. The minimal detectable change, that is the minimal change in an outcome measure that is actually true change. So it isn't really chance or just that the outcome measure is being done different. And you'll find that in the toolkit for a lot of the measures. The minimal clinically important difference. This is, again, has been determined through the literature, but this is really just meant to show you um, the change that someone's making between admission and discharge. What does it need to be to really be a significant clinical change in that outcome measure? So, if they're doing their timed up and go 3 seconds faster at discharge than admission, is that really clinically significant? Other reasons to use the standing and walking assessment tool, and some of the centers are starting to use it in this way. It lets us, if we have this information and we have it collected in a single place, it lets us look at the effectiveness of different things we're doing in practice. So if we're implementing a new activity-based therapy program, or if we're implementing the use of some type of new equipment, an FES cycle or exoskeleton use, it allows us to really look at what the impacts of that are on your clients because we're collecting all of this information. So it allows you to say, for those we're using the exoskeleton with now in our therapy, are they having different outcomes than before we were using the exoskeleton if we were to look at a similar group of people? And that can be done both just locally at your program level or on a national level because we've got all of that information together in one place. It allows you to track standing and walking outcomes from your program relative to other rehab centers in Canada. So clients coming through your center, what do they look like? Are they making similar gains to those having rehab at other centers in Canada? And then lastly, it really lets us explore some of those questions that we have as clinicians that we kind of always wonder about, and may have hunches about. But it allows us to use research and a research methodology to really answer those questions. And the answers to those questions hopefully can then feed back and inform your treatment of your clients. So examples, using predictive modeling to look at predicting overall prognosis, predicting motor recovery, and rehab potential. So some of the ways that we feed this back to you is one of the ways is through these clinical data reports. And so these come back to your facility twice a year, and it helps for a couple of things. So the first one thing it can do is give you an idea of how you're doing completing the different outcome measures on your clients. The second thing it does is it gives you back the information on what their outcomes are. So it splits clients in terms of neurologic level, C1 to T4, which is on the left here, and T5 to S5 on the right. And it shows you the mean length of stay for those clients. It shows you how they were doing on the different outcome measures at admission or at whatever threshold time they met the threshold for that measure, and then again at discharge. And it compares your center in the dark blue to the light blue, which is the national average from all of the centers collecting the SWAT. The other thing it gives you a summary of is it looks at how are people progressing through those stages at your center compared to nationally. So for example, anybody who comes in at a stage 0 or 0.5, it'll give you the percentage of those patients and the number of them that are progressing to functional walking. So reaching a stage 3 or a 4 at discharge. And then again, it'll show you your center versus the national average. So these reports hopefully can be very useful. They come out of the RISCR or the registry data. And like I said, they come back twice a year. We're always open to feedback and wanting to improve these. If they're not useful for you, they're not useful. So if you have any suggestions, chat with your clinical site lead and please let us know what would be more useful for you. And then I just wanted to give you an example of the kind of clinical research questions we have had to date that we've been able to answer using the SWAT. One of the big questions the group had at the beginning was, what of these SWAT variables at discharge from inpatient rehab can predict um, what someone's walking status is going to be 1 year after they leave rehab, or the change in their walking status over that first year post discharge, and does that look different from region to region? So this one publication was just submitted in October. Really looking at the ability to use a SWAT at discharge to predict that walking status at 1 year post. And like Shane was saying, the ABC was at discharge was one of the important measures for that. The other research question that the group had was, if you're looking at specific injury level severity groups, is there a relationship between where they get to in their SWAT stages or standing and walking functional ability and how long they've stayed at rehab? And then is there a difference between how much someone's improving in their SWAT stage from admission to discharge and how long they stay? So kind of, is there an argument that we can make from a research perspective to, if we keep these clients longer at inpatient rehab, are they going to make significantly more improvements in their standing and walking function? And does that differ from region to region? And the analysis that was done on this showed there were some statistically significant differences in terms of length of stay. They weren't really clinically significant, in that if somebody stayed, they would have to stay a whole lot longer on the scale of months to make significantly better functional improvements. But one of the interesting things we found was there were some really big regional differences. So where somebody went for their inpatient rehab made a big difference in terms of how much improvement they were getting using those SWAT stages. So we've been able to take that, and it's led to a project being led by Dr. Dalton Wolf in London, Ontario, that's looking at what are some of the reasons, or what could some of the reasons be for these differences between sites. And the point really isn't to say you're doing well, you're doing this poorly, you're doing this really well. But the point was really to say, can we pick out the things that are really important and are helping people make more change in terms of standing and walking function during inpatient rehab? And can we share that with all of the sites? I think we're always all looking for ways that we can improve our practice. And so this has led to something that we're hoping will be able to help inform that. And the last thing we wanted to share that's been done recently is we wanted to go back and get client or patient perspectives on the standing and walking assessment tools. So there was a project led out of the Toronto Rehab Institute looking at communicating standing and walking data after spinal cord injury. And really it looked at how do clients want this information presented back to them? How do they want to talk about it? What do they want to know about it? And this really found that, our current practice for providing feedback on someone's standing and walking ability is inconsistent, and that our clients are really looking for verbal feedback, at least at 2 different time points during their rehab stay. They also really wanted written feedback that would help facilitate them sharing that information with their family, friends, other healthcare professionals, so those transitioning from inpatient to outpatient. And they really, really did feel this feedback was valuable and useful for them to set their own goals and to track their own progress in terms of standing and walking throughout their inpatient rehab. So just some feedback to think about when you're collecting this information in terms of how and what you're communicating back to your clients about it. And with that, we thank you guys for getting to the end of the webinar. And you can find contact information for both Shane and I here if you have any further questions.